Hey everybody, we've got another heart today. This is number 116 in our collection. The heart would have sat roughly in the chest like this. Let me bring it up a little bit to make it make more sense. Anterior surface here, posterior surface back here, inferior surface towards the turntable, superior head, and then legs down here, left over here, and right over here. So let's start as we always do, which is by trying to identify what is the right atrial appendage, at least externally. And here we find what appears to be the right atrial appendage. It's kind of triangular in shape, pyramidal in shape, broad-based. So why don't we go ahead and open up the heart there. All right. When we do, we see that there are in fact pectinate muscles that spill outside the confines of the appendage, consistent with the morphologic right atrium. And right away, we notice that we essentially have a common atrium. There just appears to be a little strand of interatrial tissue here. Otherwise, a large defect here, and then that continues down here. And then when we look down at the atrioventricular junction, there appears to be a common atrioventricular junction. So it looks like right from the beginning, from our first look inside, we're going to be dealing with an atrioventricular septal defect with essentially a common atrium. So once again, here is the right-sided atrium here. The atrial septum would have been in this plane here, and we essentially have just this strand of atrial tissue. It's also difficult to find the coronary sinus in the heart. Don't actually see the mouth of the coronary sinus here opening up into this common atrium at all. And so remember, in the setting of atrioventricular septal defect, that the conduction system will in fact be displaced, and we can understand why as our triangle of Koch and its kind of borders are completely changed and in some instances gone here. So as we look down at this common atrioventricular junction, we see that there's just one big junction with a common atrioventricular valve. So this is an atrioventricular septal defect. Here we can see the septal leaflet, or the superior bridging leaflet. I'm sorry, I misspoke. And then here is the inferior bridging leaflet here. And then you can see the crest of the ventricular septum here. So why don't we go down to the ventricular aspect and take a look. This ventricle does have coarse trabeculations. It does have a septomarginal trabeculation here, its cranial and caudal limbs, so all consistent with the morphologic right ventricle. So we are looking now at the atrioventricular septal defect from the right ventricular aspect. And here we can see that there is a right-sided component of this valve, which seems to have three major valvular components. Here's the right-sided component of the superior bridging leaflet. Here's the right mural leaflet, and kind of has two components here. And then here is the right-sided component of the inferior bridging leaflet. You can see here's the right-sided inferior bridging leaflet. The inferior bridging leaflet crosses over the crest of the ventricular septum and courses to the left. Here's the right-sided component of the superior bridging leaflet, which has connections to the crest of the ventricular septum here, consistent with what people would then refer to as a Rastelli classification A. So Rastelli type A, for those of you who were curious as to what Rastelli this would be. So here's the right ventricular cavity here. You can see the ventricular level shunt here. And of course, we've already appreciated that there's a large atrial level shunt to this defect as well. So this is a atrioventricular septal defect with a large atrial and ventricular level shunt. When we look at the RV outflow tract here, we do find that there is a 3-leaflet semilunar valve here, all supported by muscle with no fibrous support, consistent with a pulmonary valve. Here's the pulmonary trunk here that gives rise to both the right and the left. So here's the left, here's the right, pulmonary arteries. All right. So now let's flip the heart over to the back. Here's the posterior aspect of the heart. And let's open up what we would consider to be the left-sided atrium. So here's the left atrial appendage, by the way. And why don't we just go ahead and open that up. You can see that all the pectinate muscles are confined within the appendage itself. And now here is the left-sided atrium. So here is the left atrium. Once again, we can appreciate, oh, so sorry. Once again, we appreciate that there's just this little septal strand here, and otherwise a huge atrial level shunt. And now we'll go down to what we presume is the left ventricle. It does have fine crisscross trabeculations consistent with the morphologic left ventricle. And now here we see the left-sided component of the common atrioventricular valve. And you can nicely see the trifoliate appearance of this left side. So here's the left-sided component of the superior bridging leaflet. Here's the left mural leaflet here. And then here's the left-sided component of the inferior bridging leaflet. So a nice, pretty obviously trifoliate left-sided AV valve component to this common atrioventricular valve. And what I want to point out here is that what's often considered the cleft in the setting of an atrioventricular septal defect is truly this zone of apposition between the left-sided component of the superior bridging leaflet and the inferior bridging leaflet. So when the surgeon goes in to surgically repair the AVSD and then create the left-sided and right-sided AV valves, when they try to put this together, you'll see that there'll be a big coaptation defect here. And so what they must do is they must try to approximate the superior bridging leaflet to the inferior bridging leaflet on the left side. And what they're actually closing is this zone of apposition, or this commissure here, where the superior and inferior bridging leaflets co-opt, which means this truly isn't a cleft. A cleft is, in the truest sense, an indentation in the anterior leaflet of the mitral valve such that the valve around it is flail. And here you'll see that neither of these leaflets are particularly flail. This is a zone of apposition, or a commissure, and there is no actual division of a single leaflet, which is actually what a cleft is doing in the instance of the anterior leaflet of the mitral valve, which there isn't a mitral valve here. Obviously, it's a left-sided atrioventricular valve. It divides that anterior valve leaflet into two components. Here, both the superior bridging leaflet on the left and the inferior bridging on the left are not flail. They have nice support. And this, in fact, once again, is the zone of apposition, or a commissure. And what the surgeons are closing is, in fact, this to allow for better coaptation when they try to create this left-sided AV valve, which, remember, is never going to be a mitral valve. It will be a left-sided AV valve. So once again, here's the left-sided component. You can see the trifoliate appearance with the left side component, the superior bridging leaflet, the left mural leaflet, the inferior bridging leaflet, left-sided component. This is what's being called the cleft. The surgeons will attempt to bring these two together closely to create what will then be the left-sided AV valve. We can see the ventricular component of the atrioventricular septal defect. And then here we come to the left ventricular outflow tract. There is an aortic valve up here and the ascending aorta here. Obviously, the important thing to note here is that the aortic valve is no longer wedged between the atrioventricular valves, because there's a common atrioventricular valve. So the aortic valve is sprung forward anterior to the common atrioventricular valve, where it normally sits wedged in between the mitral and the tricuspid valves. But since the common atrioventricular valve didn't divide, it had to remain anterior to the common atrioventricular valve. You can see that there is some continuity between the aortic valve leaflets and the left-sided atrioventricular valve, fibrous valvar components as well. And then the other thing to note in the setting of the atrioventricular septal defect is that often the inlet component of the left ventricle is smaller than the outlet component of the left ventricle. So once again, the inlet component of the left ventricle is shorter and has a shorter distance than the outlet component of the left ventricular outflow tract. And that's because the aorta is anteriorly sprung forward, which creates the inflow outflow discrepancy, as well as the alleged gooseneck deformity, which is in fact this. Last but not least, since we're here, we might as well look at everything. Here's the ascending aorta. It's been opened up nicely. So here's the ascending aorta. We can look down at the aortic valve now. But ascending aorta, transverse arch here, and then the descending aorta, which is in my hand. And so a heart with an atrioventricular septal defect, which is a Rastelli A with balanced ventricles, and a nice, obviously trifoliate appearing left AV valve, which I think demonstrates very well what people, unassumingly and inaccurately call a cleft.